Join us as we dissect the key components of these updates, exploring how they aim to increase predictability for model participants, safeguard against inappropriate risk score growth, and propel advancements in health equity.
Great. Good morning, everyone. We are happy to have Dr. Decker again join us for our new podcast. Today, we'll be talking about the 2024 updated changes from CMS on ACO REACH model. We have discussed this model before, and there are some important changes that has happened in this model. Dr. Decker, what do you think of this Biden-Harris government's changes to our ACO REACH model?
Pretty exciting stuff. You know, before getting on this call, I know that we were talking, and it surprises me, but then it doesn't surprise me. I think that these are all the things that we all in the industry recognized very early on that were going to be or have been problematic. And I think that, CMS, I'm really impressed. Kudos to you, CMS, for acting so quickly, but impressed with the quick changes in which they're trying to turn things around and I think make things right, and all the things that we saw, right, that were challenges: determination of the base year, attribution, the various levels, the various governors that we talked about early are all being impacted. Moving to V28, that recognition, and I know I'll probably be considered controversial in saying this, but I really see it as a nod to moving towards that centralized healthcare. And while the actors may change, the program largely runs very similar. And so, we'll see something that's very like, I think the best of what we know from Medicare Advantage to what we know about ACO and fee for service, and trying to bring that together to come together with a cohesive model that really furthers, right, that quintuple aim.
But going back to the ACO REACH, what's surprising was that the attribution bar was lowered. For me, that was a surprise. I know many of our partners are also struggling with attribution, so that is a good surprise. Not surprised with adding more information on the SDOH side of things. They have expanded the SDOH and patient characteristics, and I think these changes will satisfy many concerns, and that will go some ways to make the participants satisfied. There are also changes with risk adjustment model, and we just talked about that, Dr. Decker, that they are not talking about V28, but now in this update, just like all the Medicare Advantage plans, and the benchmarks again in ACO REACH, as you are well aware, are based on those. So again, we'll see that shift occurring next year. I think that is an important shift. What are your thoughts on the risk adjustment changes?
I agree. I think it's an important shift, and I think it's a nod to this is what they believe is appropriate as far as reimbursing for care, right? The intent is to provide monies that then further the care and provide for the care that you're expected or that we would typically expect to provide to those patients. And so not surprised at all. Maybe surprised as far as the timing, it's coming pretty quickly. But like I said, I think that, I don't know, there's something since the pandemic that we're willing to move a lot faster, and definitely see a lot of more rapid changes coming from CMS around our healthcare system.
I see this shift occurring towards a more holistic approach to patients, whether it's the ACO REACH model or Medicare Advantage payments. They're going away from this low-hanging fruit of risk adjustment to boost your numbers, if we can talk so directly. And I think now we have to think of a more holistic way of doing population health management, really take care of the patient, prevent those acute admissions, readmissions. Any thoughts on that trend CMS is showing us?
No, absolutely agree. It's the whole point of the program, right? And value-based care. And I talked about this on another webinar, and I know we've spoken about this too, but it's about that. I think of it like a three-legged stool. And so if you really want to improve healthcare, you have to think about the whole picture. And it's not just about capturing the acuity, because what's the big deal, right, of capturing the chronicity and the entire of it if you're not doing things to try to manage that? And so, doing everything that we can. There was a problem in healthcare. That's why all these programs were born, right? The costs were out of control. Patients weren't necessarily getting better quality care. And so in order to try to reverse that, right, it's not enough just to document where that patient is. It's really trying to disrupt the trajectory. And I think of it, and my MBA professor would roll over. I'm probably using it inappropriately, but I think of it as this arbitrage moment, right? Where the typical trajectory and the cost trend of a particular patient. Say someone would, and I'll use a different one other than diabetes, the complications. Say someone with COPD. We know what the cost trend is for that. If we're not doing things, right, to control quality, to ensure that they're getting appropriate screenings, that they're taking care of all the parts of their health, if we're not addressing social determinants of health that then impacts total cost of care, we're not doing anything to change anything. We're just being really good note takers. And that doesn't really serve anyone, just to sit there and, oh, can you hear me? In my mind, that doesn't, to admire the problem, I guess you would say, doesn't really do anything, right, to change the situation. And so if we truly want to, make a change, get to that quintuple aim of right care, right time, right cost, right, without burdening the providers and ensuring, equal access to healthcare. If we want all of those things, we have to address all of those other components as well. It's not enough just to capture conditions. And so I think that V28, a lot of the rules that we see, the requirements around RADV, right, all of this different legislation that's coming out are all directed at trying to shape that and get us to move in that direction.
Excellent. So, Dr. Decker, that is my understanding, and I think we are on the same page in that now we need all the data about the patient, and we really need to take care of the patient. And you are doing a lot of speaking at these conferences and meeting a lot of folks out there. Do you think this is where the industry is, or you think that there's still a lot of dust out there and people are trying to make sense of all these very rapid changes?
I think folks are still trying to make sense. It's kind of like trying to move the Titanic. You see the iceberg, it's coming, but you got to get out of its way. And so it takes time to move some of these larger organizations. And then, I think it's like with any change that comes, and there's a lot of theory out there about change and organizational change. And I think we're experiencing it, right? And so I would look to that to help kind of guide my way through it. But just seeing, there's some folks that deny it's happening. They don't want to believe it, sticking their head in the sand, if you will. Others that are running for the hills and think the world is coming to an end. And then there's other, the majority that's really trying to navigate and determine the best way to go. And, just like with any adoption curve, I think we see the same thing here, right? We see some folks that are going to be early adopters on the forefront, really guiding how to work with that change. You're going to have a lot of folks that are going to wait to see what those early adopters are doing, to use that to kind of, follow their path. And then you have folks that, are going to take a while to come along, may never come along. And those are your groups, I think, a lot of times that become obsolete and find their way out of healthcare, right? Or find their way out of the industry because they've just worked their way out that way.
Serious stuff. So people really have to move along with CMS, and they're moving pretty fast. They were also changes to the HEVA benchmarks. Previously, it was $30 for the top 10 percentile, but now they are also deducting about I think $10 PVPM for the bottom 3 deciles. That's a new change. You think after this, people will really give attention to S2H now? I was talking about that there isn't much there. This kind of very beginning of S2H data, but in these changes, I really feel that now we are talking, and this is significant, and now people will pay attention to getting this data. What are your thoughts on that?
Absolutely agree. And again, I want us to think about it. And this is a point I should have made earlier too, about don't just focus on individual components of the program, right? There are some folks that just say focus on risk and aren't really paying attention to SDOH or thinking about SDOH of how they're recording it. It's not enough to record it, right? You also have to look at what are the programs that you're going to put in place to try to shape it, to try to address it in the best way that you can. And I think the groups that are going to be successful, the ones that are really going to, I personally think, survive, and it's not just about surviving, right? It's about thriving. Those that are truly going to thrive in this environment are going to be those that can make those connections, that can get that data, use that data, make it actionable, are all going to be important to being successful.
I think the data remains critical and central to all the value-based programs, and now it's really, really critical for ACO REACH model updates in 2024. And we really have to focus on how to incorporate this data from different data streams, HIEs, ADT data, claims data, clinical data, how to build a longitudinal record, and then how to use the data. I think the data becomes even more central now, now that the bar is a little bit higher on achieving some of these things. Any thoughts on more on data?
Yeah, no, I couldn't agree more with you. I think that data is where it's at, and we have so much of it, right? But it's about making it useful and making it actionable. And I think the exciting, but also I feel like I'm base jumping with ACO REACH because it's not, it's about getting that data, acting upon it, but the window is much tighter with what you can do. And so having that data up front at the point of care, that you can actually do things then, right? When the patient's in front of you, capture their risk, do whatever counseling you're doing, help with whatever programs, is so critical to being successful. And so we have tons of data out there, but it's looking at what is that data telling us and not relying on data for data's sake. I think sometimes, we see a number and we grant this, trying to think of the word, but, we automatically think that, oh, it's in a number form, it must be right. And we need to question the data. And so while there's lots of data out there, not all data is good. You shouldn't just accept all data just because it's in a numeric form. It doesn't necessarily give it credence that you would want to stake your program on it. And so really looking at the data that's out there, slicing and dicing it in different ways, understanding what's under it, how it comes together to put together that story, and then how you, right, being an honest assessor of what your abilities are as to what you can do to make changes and where you can be successful, right? And not everybody's going to be good at everything. But knowing where your strengths are, knowing when it's time to bring in maybe additional help, so on and so forth.
We have a unique approach to data at Persevere, and we've done a lot of work on that, Dr. Decker. This is something which I'm really proud of our team. What we have done going back about a decade is to build machine readable data units, and they are units of analysis and unit of care management, and they are based on concepts such as based on conditions or risk or cost. So you can combine different axes of data together to build these concepts together to analyze the data and then to reach out to the patients in a care management or care coordination format. And these machine readable data units are really foundational to our platform, and they really allow us to slice and dice the population and to really target the population for care coordination. This is one way that we have done in our platform, and you're familiar with that.
I am. I will go on record to say that I think Persivia is the best model that's out there. I really appreciate, before talking about the care management piece, and I'll get to that in a second, the way in which you can take in data and standardize it. The data that's coming in is different, right? Every EMR system, things that are out there are all different. How are you bringing in that data and making sense of it? If you're not doing that when you get to that aggregation, you run the risk of, again, not having that cogent story, right? Or telling a story that no one really understands because you got a data, a set of data where maybe a certain field, right, was mislabeled or didn't come across or got truncated, and it can throw everything off. And so it's really important to have people not only understand the clinical aspects like you do, but understand the data aspects too, which I know, several folks within your organization know. Now you get that in there, right? It's aggregated. And then how do you communicate it out? And I think you brought up something that was very important. Whenever I think about programs, I think about what are the 3 levers or levers that I can act on to make this system go. And as it relates to risk adjustment or even value-based care, look at who the primary actors are. It's going to be tools and technology, right? It's going to be the physicians, and then it's going to be the patients. And I think that it's all great to have that data sitting at your organization, but if you don't have a way to push it out, interact with patients, as you said, in those care management platforms, being able to encourage them. Patient engagement, it's amazing. It was important before, but it's becoming more and more important, especially as, the challenges become more challenging, right? That healthcare becomes more complex. And so having that ability to share information across your differentiated team, use that information to communicate with patients, to communicate with providers, all really important. So really goes back to that point I was making about it's great to have all that data, but you have to be able to tell a story, and you have to tell that story differently depending on who the audience is. Because if it's a patient, if it's a care manager, right? If it's a physician, if it's a CFO in an organization, that story has to be different. You need a system, and you need people that know how to be nimble to get that information out there in a way, again, that's ingestible.
Absolutely true. It has to be a collaboration between finance, care management, physicians, and now patients, who are an important part, and they have a seat on the table. Thank God. I think we waited long enough for that. So that's a good change. And that is what Care Space is, a platform where teams can come in and collaborate with each other. And what unifies all this is, as I said, the data units, which we call semantic sets. Just like you said, if somebody's, for instance, coding diabetes by A1C or by ICD-10 or SNOMEDs, or semantic sets are machine readable and they understand that. And we monitor that data streams, and we see, as you said, if it's truncated, if it's not really up to the mark, we monitor that at data level first, because data is very critical. That's what I feel, for you to make sense of it, whether it's for analytics for your CFO or your analysts, or whether it's for care management for the provider group, or reaching out for patient engagement. If the data part is done correctly, these things are actually enjoyable, and they bring a lot of value back to the organization. But if the data is not great, nothing really works out well. It's like the blood of our system. The data flow is very, very critical. And I think with these new data becomes even more important to capture all this data appropriately. That is one thing I think organizations should focus on. It's been a long journey for us to build these semantic sets which are machine readable, so that we can collect this data, pass the data, do normalization of this data, and then feed it both. To us, the analytics and care management and patient engagement is the same paradigm. It's the same data sets which we feed into all these systems, so that eventually the CFO can know how much impact the care management programs are having on the ROI. And similarly, the care managers can know what impact are on their costs. So everything is shareable, and it's the same lexicon or language, and the semantic sets help each partner to understand what's going on with the patient. Eventually, it's the patient who's at the center.
Couldn't agree with you more. And the other thing, that I think folks fail to recognize is that just like the rules that we're talking about today have changed, the data changes too, and what the rules are around that. And so making sure that you're up to date, you really need to have good stewards that are monitoring the system to make sure that your link codes didn't get, out of whack, or that you have the most current specialty table, right? So that when a physician is submitting a claim, if the specialty code that's identified as risk adjustable by CMS, if that's not updated, right, you run the risk of losing, having that attributed to that patient. Or even we know diagnosis codes get updated all the time. And so being ready, having someone to do that, it's complex enough. Trying to do it all on your own, I think, is particularly challenging. No one really has the time for that, right? Unless you have good partners like yourself that's monitoring that and making sure that when the data gets truncated, you see that. Because folks that are at the administrative level, those physicians that are meeting with patients, they're not looking for those things. They're focused on the patient, where their focus should be, right? They need others monitoring the data, making sure, again, that it's coming together, like you said, in a way that tells a story, right? That's important to them, that they need to hear, that has meaning.
Great. Thank you so much. Thank you for joining us today. Thank you. Take care, everyone. Bye-bye.